Thank you. No, I know. It's more the title. I'll spend more time on this slide than on the rest, but thank you so much. I also have to leave after this to catch a flight, so I apologize. I'll just be sneaking out after. But good afternoon, and thank you for the opportunity to speak. My name is Laura Tiusaba, and I'm a pediatric colorectal fellow at Children's National in Washington, D.C. And I've been working with our scientists from the Sheikh Zayed Institute of Pediatric Surgical Innovation to bring you today's update on our technology on how near-infrared speckle dye-free imaging in a swine bowel ischemia model could replace indocyanine green, or ICG, fluorescence angiography to assist tissue perfusion in an anastomosis. This guy? The green one, thank you. Perfect. So we recognize that accurate assessment of bowel viability when performing gastrointestinal anastomosis is vital in achieving successful outcomes, and that poor local oxygen delivery due to inadequate blood perfusion poses a major contribution to their failure in terms of stricture or leakage. Current methods are not ideal. We're talking about surgeon's visual inspection, which is subjective, skill level dependent. And the fluorescent angiography, ICG, is invasive and requires dye injection, can be time dependent and time consuming if you're talking about multiple injections that are needed. For this reason, the development of real-time visually augmented dye-free optical devices for intraoperative bowel viability assessment would significantly improve practicality and patient safety. We're talking about reducing operative times, allowing for optimal preservation of bowel. In our pediatric population, we're talking about kids making a difference between short gut and kids that we can leave more bowel, and ultimately decreasing postoperative anastomotic leaks. So near-infrared fluorescence imaging with ICG has been studied as a tool to assess perfusion of bowel anastomosis. And more recent studies have focused on the quantification of this data, such as this is a study from Japan in which ICG's time to beginning of fluorescence, slope and peak intensity is used as predictors of an anastomotic leak in patients with laparoscopic colon resections for colon cancer. And ICG was noted to have faster onset of fluorescence in those that did not have an anastomotic leak. Similar analysis of real-time dye-free anastomosis model has not been described. So our setup in our animal facility involved, this is the initial part of our project, is a non-survival stage, designing a swine bowel ischemia model in order to analyze the acceptable resection margins prior to performing a small bowel anastomosis. We began by, hopefully the videos play. Okay. We began by analyzing our own ICG data. Let's see, oh yeah, it's playing, good. Thank you. And as pictured here is the segment of healthy bowel and a transitional segment which has the undermined mesentery. And as the video goes on, you can see and appreciate where that peak fluorescence is, which in vivo, again, it continues to be subjective, and you're kind of left wondering when that maximum point was and where in the bowel is your ideal resection margin. We began again, so this is our own ICG data. Pictured here is a segment, images extrapolated from the video are analyzed post-operatively to kind of quantify those fluorescent of time and maximum intensity that can be calculated. This is all, again, post-operatively. In this particular image, we aim to portray that quantitative model of indocyanine green. It allows for objective data analysis. However, again, this is all done post-operatively. In this particular, we then use label-free angiography, in particular laser speckle contrast imaging, or LSCI, which some of you may be familiar with, which is a dynamic light technique where laser illuminated images of perfused tissue capture a speckle pattern when integrated over time scales comparing motion dynamics, results in a visible blurring. And in this particular case, the red blood cells inside of the blood vessels serve as a scatterer. The theory behind this non-invasive real-time, so a little bit of the science behind it, is that the speckle contrast, or K, is inversely proportional to the mean intensity. So in other words, low contrast corresponds to increased movement of the scatterers or high velocities with faster moving particles, being depicted in it as darker 2D surfaces. Speckle arises from the random interference of coherent light, in this case a laser, and from that scattering of the red blood cells, and the high-speed, high-resolution camera picks up this information regarding the fluctuations of speckle pattern, the blurring movement. This concept of label-free angiography has already been described, and its application in minimally invasive surgery as a rigid laparoscope with an integrated light source was introduced by our lab in 2018. And we see here how it was first utilized in a rat model. As mesenteric vessels are clamped, then real-time information regarding perfusion can be analyzed. We also recognize that LSCI alone, without information on oxygen saturation, we believe has a limited ability in providing, once again, quantitative data with respect to tissue oxygenation. And because of this, our model utilizes synchronized hyperspectral imaging and combination into a working laparoscope. And it becomes a multi-modal imaging system capable of both non-invasive and quantitative perfusion assessment. So here we present what the real-time, here we go, the video, imaging looks like on our swine small bowel model. And then here followed by that same previously analyzed ICG bowel segment with the transitional segment with the undermined mesentery. So here our imaging in the center is depicted as a single, depicted side to side with our ICG results. Our model is a still frame, again, of that real-time data, which is comparable to ICG. And of course, again, this is only able to be done post-operatively. Just another shot of the cartography between one and the other. This is our earlier version of the model, just some pictures of our earlier work. And this is kind of the conclusion and why I'm here today. So far, 3 swine models were used to study segments of normal, transitional, and ischemic bowel limbs. In all combinations, both ICG and LSCI predicted shorter segments of non-viable bowel compared to visual inspection alone. And in one of our models, the one shown here, where the adequate perfusion signal or coloration was determined to represent the demarcation of viable bowel, the distance from the anastomosis margin is shorter in LSCI, allowing us to predict that with further analysis and training of our model, near-infrared laser Speckle dye-free imaging could replace ICG to assess tissue perfusion when making an anastomosis. I would like to thank you again for the opportunity to speak, and to my team back in DC. Thank you.